everybody, and welcome to the New Teeth Now webinar. My name is Bianca, and I'm here tonight with Dr. Richards. And tonight we're going to be talking all things dental implants and full mouth dental implants specifically.
Yeah, primarily full mouth.
Yeah. We're so glad that you've joined us tonight, and we're super happy to answer all of your questions. So feel free in the YouTube chat area to type your questions there, and we'll answer as many as we can tonight. Give you some really good information to make some informed decisions.
Yeah, and I think, since you are on this webinar, you're obviously interested in this. And what we have found is that a lot of people who come to see us have been to 2 or 3 or more other consults, and they have a lot of questions about why we do things the way that we do. And so if you have questions relative to our process and why we do it that way, I wish that you would ask that question so that we can give you as much information as possible. I mean, that's the goal here. The goal here is to educate you and tell you what we do and how we do it and why we do it to help you make some kind of decision. So I'll let Bianca talk some.
So let's get to know a little bit about Dr. Richards. So he is a board-certified oral and maxillofacial surgeon since the early 1980s, and so he has over 40 years of dental implant experience and is an innovator of New Teeth Now. And I just think it's great for you to kind of explain how far this actual procedure has come over these last 40 years. To what it is today.
Yeah. Well, I've gotten to be an old man doing this stuff. Started doing this kind of work in the early 80s when the Brandemark system was first approved by the FDA and released in the United States. We were doing the lower jaw only. I was working with a local lab called Crown Lab and Mike Howard, and we did teeth in a day, teeth in 3 days, teeth in a week. We tried teeth every which way but loose. And it's just sort of snowballed from there. Things ultimately became approved to be used in the upper jaw. And so we started doing the upper jaw. In the old days, we were primarily doing sinus lifts, which really slowed the process down, like a year to have a sinus lift bone graft healed, and then put implants and have them healed. So that takes about a year. In the early 2000s, started doing zygomatic implants. Was really way up ahead of the curve on that particular type of implant. And that has just revolutionized the treatment of the upper jaw, which is called the maxilla, the upper jaw. And so since the early 2000s with zygomatic implants, we've been able to offer almost all of our upper jaw clients immediate restorations, and find now through the studies that we have done that probably 85% of all of the upper jaws that we do require at least one zygomatic implant. And we haven't really looked at all the numbers, but it seems like we're doing more and more people that require 4 zygomatic implants. So there's been a big evolution from the 80s, from the lower jaw only to incorporating the upper jaw with bone graft technology, which took a long time, so we could not provide teeth the same day, to the zygomatic implants, which allowed us to give folks teeth the same day. And of course, even zygomatic implants have evolved so that the techniques that we're doing in 2025 are different than the techniques that we were doing in 2005. So all things considered, things are a lot better than they used to be.
Yes, it's made
a lot better.
A long way. Even though the last couple of years has been major differences too. It's really awesome.
Implant technology and just what you have to understand about our business is that there's two of us that do this kind of work, Dr. Kirkpatrick and me. And this is all I do, pretty much since about probably the last 10 years, since 2009. Most of what I do has been full arch, immediate teeth, leading up to a full set of teeth. I mean, it's almost, so now it's all I do, and do it 4 to 5 days a week. So every week I do 4 to 5 folks procedures every day, and my partner does the same thing. So you can do the math, how many of these we do. And so, which kind of brings me to another point, to where if you wanted to have your knee done, would you go to someone that did 1 knee a month, or would you go to someone that did 30 knees a month?
Yeah, that's a big difference.
So would you go to someone who does, a heart surgery every day, or two heart surgeries a day, or would you go to someone that does 1 a month? I mean, it only makes sense you go to someone that does it all the time, every day, because they're going to be better, because they will have seen all the problems and, have answers. And so one thing about this business is that we have a growing segment of clients who have been treated at other offices, primarily general dentists, who are not happy for one reason or another and have to have everything redone. And this is a growing segment, 1 or 2 folks a week. So, it's just one of those buyer beware things. But, the question from Bianca was to explain the evolution. And that's been the evolution to, move through, to incorporate zygomatics, to see this field blossom to where everybody and his uncle on every street corner is trying to do this. And so then now there's a whole nother clientele who's coming to us. It's the clientele to be fixed up.
Right.
Not to have a primary procedure, but to be fixed up from their primary procedure. So anyway, that's kind of, where we are at this point in time. We will, through this webinar, discuss our business model, which we feel is very unique in the field. And you'll be seeing our dentist, our lab, our milling center. You'll be seeing all of the things that we incorporate into our business model, and it's all done so that our clients have a better job.
Yes.
So with that intro, we can kind of move on through it.
That's a great intro. And we did have some questions. Might as well, we had a couple come in. So
Yeah,
so one is just it's just a comment. So Tammy said that you did her teeth yesterday, and she wanted to thank you again. She loves her new teeth, and she's so grateful for her smile.
Isn't that nice?
So yeah, that's really sweet. Where are we located? We will get to that, but where are we located right now?
We're in Lakeland, Florida, dead center in the state of Florida.
Yes.
Yep.
Okay. My problem isn't just gum disease. It's also a mouth full of rotted, crumbling teeth. Some so broken the gum has grown over. Would they need to be extracted before the procedure?
So the answer to that is we would see a person like that, do all of our usual and customary. You would see one of the surgeons first to review the CT scan. And in reviewing the CT scan, we look at the upper jaw. The upper jaw is called the maxilla. And we're primarily looking for the thickness of the bone, the depth of the bone, and the configuration of the sinuses, so that we can tell a person, are we going to do tilted implants, which we will discuss later, or are we going to do zygomatic implants, just how we're going to manage it. Then we talk about the lower jaw, which is, the medical term is the mandible, and there's a nerve in that jaw we have to be aware of, and we talk to folks about the width, the depth, and where's the nerve. And then we fabricate a plan. I like to have my patients understand why the plan is what it is. What am I seeing that makes me want to do things that way. And it really helps if the person, the patient, understands. And so a big part of our consults are education. So then if a person wants to move ahead after seeing the surgeon, they go to the restorative dentist. We have 3. And they go over everything from a restorative standpoint, all about the teeth. They do digital scans, they take photographs, talk about everything. And then after that, the person has had a complete education about the restorative end of things, a complete education about the surgical end of things. They know all about all the visits it's going to take, this, that, and the other, and they can make a final decision about moving ahead or not.
Right.
So, to answer your question, no, the teeth can come out the same day, all one big procedure, teeth come out, bone gets cleaned up, implants go in, we do digital impressions, and we make the teeth the same day. You do not have to have the teeth out and then wait 6 months for that to heal, and then wearing dentures. We hear that a lot. They want to take my teeth out, put me in dentures for 6 months, and then come back and do the implants. No, we don't do that. It's all done one day.
Awesome. And we will come back to more questions. So just so we can get a visual for people who maybe haven't seen like what the implants look
Right.
like, things like
Yeah.
that. Really good questions. So this is a fixed upper hybrid, and what's someone looking at when they look at this image?
Well, they're seeing teeth, and they're seeing pink stuff that would be fake simulated gum tissue, and then you're seeing through the bone, into the bone where the implants are, and so then the implants are in the jawbone. The implants are not in the gum tissue. The implants are in the jawbone, and then there are connector pieces attached to the implants that connect the teeth to the implants. So that's what you're seeing.
And then the lower jaw, very similar.
Yeah, very similar. You're seeing the teeth with gum tissue, and then the implants in the jawbone with the connectors. The connector pieces are sticking up through the tissue, and then the teeth sit on the connector pieces and are screwed down to those connectors.
And we refer to this procedure a lot as like an all-on-X.
We've heard it called that,
kind of.
yeah, all on X.
And
Yeah.
that is kind of because we don't necessarily only place 4, we place what the patient needs. So that's why like this image had 6, for example.
Yeah, it does.
Um,
I usually do 5, sometimes 7. A lot of times there's not enough room. There's the nerve. Remember I talked about the nerve earlier, and you have to be mindful of the position of the nerve, and sometimes there's not enough room to do 6 implants and space them out like this fixed lower hybrid slide shows. So typically I'll do 5. And then if there's bone in the back, I'll do 2 more short ones in the back, so they have 7.
And speaking of the nerve, we had a question about that. What if the nerve in the lower jaw was accidentally hit during surgery? Could it be repaired?
It's not hit accidentally during surgery. I mean, that just doesn't happen. But could it be repaired? That'd be depending on how bad it was hit. There's no nerve in the front. Let's wait till we get to a couple of x-rays.
Okay.
But that show the nerve.
Yeah.
But the nerve comes through the jaw to about the corner of the mouth, and then it comes out of the jaw. And most of the time, the implants are placed primarily through what we call the premolars, the bicuspids, and we cantilever off a molar. If we're going to put implants in the back, there's got to be plenty of bone so you don't accidentally hit the nerve. And our CT scans show exactly where the nerve is. So there's no excuse really to hit the nerve.
Yes.
Yeah.
That's great. And we did, Dr. Richards did touch on this briefly, but I'm going to go into like what the day of surgery would look like a little bit more in depth. And so the patient would come in around 7:30 in the morning. They're put under a deep sleep with general anesthesia, so it's completely pain-free. Then the teeth will be extracted if the patient has teeth still. Dr. Richards will replace all of the implants necessary. And while the patient is still asleep, we will take digital impressions for our in-house lab to customize those teeth. The patient would wake up in a private recovery room while the teeth are being fabricated to be placed the same day. So around early afternoon, mid-afternoon,
Right.
the teeth are placed in the patient's mouth and adjusted, and then they can go home. So that is a simplified version of
Right,
surgery.
very simple, but
Yes.
summarizes it very well.
And some of our innovative technology, we can kind of show you how the digital scanning has been working.
Yep. We used to take impressions with various materials, but this instrument is called a micron mapper. And you can have, well, that shows Ashley, and they're taking that micron mapper and taking the impression of the implants in about under 10 seconds. And how does that work? How it works is like this right here. It reads those scan bodies, which are kind of like digital camo, and once it has read all of those and they all turn green, then the impression is taken. After we do some of the other things that we do during the procedure, the teeth are digitally scanned, and then they are emailed to Roxy over at the milling center, and Roxy fabricates a digital file of the teeth, and then it's sent back to our main office where Terry prints the teeth on a 3D printer. They have to kind of clean them up and dress them up and paint them, and then they are placed into the person's mouth.
It's pretty
So,
awesome.
Yep.
You know, we'll be able to see a little bit of that painting at the end here. They turn into like actual teeth. It's pretty cool.
So these are made out of a material called onyx. It's a liquid ceramic material. So they're very nice, they're very strong, and most of the time by about 3 o'clock, something like that, about 3 o'clock.
And that kind of brings us to why we do things all in one office. And it's just how cohesive the whole process is when everyone communicates and works together. So we have our surgeons, our dental lab, and restorative doctors all here. We're all on the same team, and it makes a better outcome for the patient. Makes things more streamlined and just better overall.
How can you even think about doing it any other way?
I know.
We came to this realization over 10 years ago when we built our lab in 2013. And it's just been that business model ever since. Dr. Dibbs has been with us ever since that time, and Dr. Perez, Dr. Dibbs are full-time, and Dr. Nofala is a part-time local restorative dentist. And so we have the support of, say, 2.5 restorative dentists to work with our patients in fabricating the teeth and that sort of thing. And I'll go into the teeth part a little bit later,
Yes.
about how unique we are with the tooth part.
And our locations, we have an office here in Lakeland. That's where we're streaming the webinar, where Dr. Richards works out of, and also in San Diego. So wherever you are in America, you're halfway at least to get to us, one of our locations. And then these are all our surgeons as well. So we have Dr. Richards and Dr. Kirkpatrick in Lakeland, and then Dr. Shrafi, Dr. Evans, and Dr. Z in San Diego. And then we had one more question before
And the other thing is
Yeah.
all the surgeons are board certified
Oh, yes,
oral and maxillofacial surgeons. So when you're board certified, that means you have met a certain standard in your peers. And so all of the surgeons have completed a residency program after dental school, so 4 years of dental school, and all of our surgeons have gone anywhere between 4 and 6 years after dental school to a hospital-based oral and maxillofacial surgery residency, and we're all board certified.
That's an important
Yeah.
distinction, especially if you're doing research to find out the education of who your provider is.
Yep.
For sure. We had a question about anesthesia. So, does the anesthesia nurse stay in the operating room during the entire surgery to make sure I don't wake up?
Yes. The way that works is all of us as the surgeons have licenses to administer general anesthesia in the state of Florida. The nurse anesthetists sort of work under our oversight. The nurse anesthetists do the entire anesthetic, and they are in the room the entire time, just like in the hospital. In the hospital, I did a repair of a broken jaw Saturday. So the anesthesiologist came in for the placement of the breathing tube. As soon as that was in, they left. The nurse anesthetist managed the entire case, and that is how it goes all around the country. Anesthetics are managed primarily by nurse anesthetists, and our nurse anesthetists are no different. Most of them have jobs in hospitals or outpatient surgery centers when they're not in our office, and we have 5 that rotate through, and they're all excellent. So they stay in the room the entire time. If they weren't in the room the entire time, that wouldn't be right. I mean, you know, that's their job, to manage the anesthesia. And all of our procedures are done with a breathing tube in through the nose so that we can work in the mouth. So we're talking real general anesthesia. This is not twilight sleep, it's not IV sedation, it's not deep IV sedation, it's full-blown general anesthesia. And that is the way we do our procedures, unless there's some medical reason not to. You kind of get me off on an anesthesia tangent, but one thing that we end up chasing a lot are medical clearances. And so the population that we do these procedures for is typically, you know, up in the 60s, 70s, or 80s. And so folks in that age bracket, they're all on medicines of some sort. They all have a doctor, you know, they all have something. Mm-hmm. And so we are forever getting medical clearances, cardiology clearances, pulmonary clearances, endocrine clearances. I mean, we're clearanced out, but you know, that sometimes is the biggest holdup, just getting all the medical clearances for the anesthesia and the procedure. But to go back and answer the question, it's a simple yes.
Awesome. And we also love just showing.
I like that question, though, because she wants to make sure she doesn't wake up.
Yeah, it's important. You don't want to wake up.
The nurse stays there, whether it's a male nurse or a female nurse, to make sure that you do wake up at the end of the procedure. So anyway, that's just kind of funny.
That's funny.
No, you won't wake up during the procedure. No.
You'll wake up right on time.
Wake up at the end.
Yeah. And we're going to hear from Jennifer. So she had a lot of bone loss and periodontal disease and just kept putting off, you know, taking care of her teeth. And we'll see how this has transformed her life now.
What's going through my mind is that that's the old Jennifer right there and the old smile. Thank God I did something new. My name is Jennifer, and I'm a real patient at New Teeth Now. I came to New Teeth Now because my teeth were just messed up, and I had 90% bone loss. I had periodontal disease. It did accumulate over the years, but I also kept sweeping under the rug. I'll deal with it later. I'll deal with it later. And so it just caught up on me, and I couldn't deal with it later. My jaw would hurt, my ears would tingle. It just hurt to eat. It is painful. It was hot or cold stuff, was very sensitive, and my teeth would not stop bleeding. To the point I'm driving down the road to the dentist, spitting in a cup because I did not want to swallow it. And he was like, I can't help you here. You have to go see a specialist. So that's when I ended up at New Teeth Now. So I went in to see Harley Richards, board certified oral surgeon. He went to school for it. He knows. And I like how he gets excited about like new equipment he gets and stuff, and kept me at ease, talked me through all my steps. I got up early that morning and I was nervous. I could tell you I was nervous, but once I got in there and they put the little happy gas, let me go to bed, I woke up and I was fine. Holy cow. Oh my God. Oh,
They do look pretty nice.
ew.
Yeah, they look really.
I love them. Oh my God. That's $1 million smile right there. They did amazing. Amazing. They just feel good. Thanks to new teeth now, I can eat what I want. I feel good about myself. I can be comfortable in my own skin. I can smile. I can be healthy. I can do the things I want to do. It's a total booster. I smile more now. As before, I would just hide them. And now I'm just all smiles. Every time somebody looks at me, they're like, you just keep smiling. I'm like, I have so much to smile for. If you're on the fence on it, do it. You know, you won't regret it. You only live once, you know, and if it's an issue and it's concurring and it's been like this for years, you wasted all this money in this past couple of years. What is a little bit more to get it right? Just do it. You know, you won't regret it. It's the best decision I've ever made. Because that's $1 million smile right there. Nobody can take that away from me.
And we're gonna look at some scans. So
Can't really see. We gotta get some
Can you see the
clearer.
nerve?
We gotta get some clearer.
with the nerves there. Yeah, so it's hard to see the nerve in that picture. I wonder
Yeah,
if the next one will.
we'll get a clearer X-ray for the future.
But what are we looking at here?
So these are, as it says, traditional implants. And what is a traditional implant? It's of a normal diameter. Typically, we're using implants in the 3.5 to 4.5 diameter, occasionally something wider. And we're using implants that range from 10 millimeters in length up to 18 millimeters in length. And those would be what we would call traditional implants. Now, the technique, this is called a tilted technique. And we tilt in the upper jaw to tilt in front of the sinus. And we tilt in the lower jaw to tilt in front of that nerve that we talked about. Now, this film is not a good film to demonstrate the nerve. And I was just talking to Bianca. We will get, for future webinars, a clearer film that shows the nerve so that that is something we can talk about and demonstrate. But the tilting in the lower is tilting in front of the nerve to avoid the nerve, but to throw the working part of the implant more to the posterior. So by tilting, the body of the implant goes anterior, and you can see the working part of that where that other piece goes in. That's the connector piece. The terminology for that is the abutment. You can kind of see where that connection is. There's a little step off there. But this is probably most of what we do, traditional technique. Works very well. Now, this is also very common, and this does have the nerve, particularly as you are looking at that X-ray to your left, where that short implant is. And you still see the tilting, and if you go down below the tilted implant, you'll see that black round space, and that's the hole in the jawbone where the nerve takes a turn and leaves the jawbone. So in between the hole on the right and the hole on the left, there's no nerve. But if an implant is going to be placed behind that hole is called a foramen, the mental foramen. So if an implant is going to be placed behind that nerve, the implant has to be short enough that it doesn't injure the nerve. Now, these implants are short, but what you have to understand is a lot of time there's an undercut. And even though it looks like there's a lot of space between the tip of the implant and the nerve canal, there's really an undercut there. And so that's as long as that implant could be. And so that is a common technique when the person has enough bone. And then you can see in the upper jaw, the zygomatic implants, those are the long ones. And the zygomatic implants, they range from about 36 millimeters to 55 millimeters because they have to go out and plug into the cheekbone. And those are placed when the sinus comes too far forward for a tilted implant to give us the mechanical advantage to get that working part of that implant enough to the posterior. Or the ridge is very thin, like less than 5 or 6 millimeters in thickness. And so that's a typical zygomatic technique where there's traditional implants in the front and zygomatic implants in the back. Those zygomatic implants in the back have replaced the sinus lift. These zygomatic implants allow us to attach teeth to those implants the same day. This person gets their teeth that day. No bone grafting. The benefit of zygomatic implants is you get your teeth the same day, no bone grafting. And once again, you know, if you're dealing with us, if you're dealing with Dr. Kirkpatrick or me, you're dealing with people who might do 8 or 10 or 12 zygomatic implants a week. And so we're doing them all the time. And, you know, we pretty much have it down. So typically there's no, you know, long-term problems with anything, really. So.
And we also have I'll kind of play this for the zygomatics, just so people can kind of see what that looks like as well, of being placed in the cheekbone, and how the implants are attached, or teeth are attached.
And so that would be the typical 4 traditional implants up front and a zygomatic on each side in the back. And you can see where that screw hole is at the tooth in front of the molar. One thing I don't like about this slide is it shows that that person's getting 2 molars. Typically there's a 1-tooth cantilever. The person's going to get 1 molar. Otherwise, it's a very good little slide.
Awesome. And then we had a couple questions. How can regular brushing keep the post between the gum and the prosthesis clean? It doesn't seem like there's enough space for the toothbrush.
The post between the gum and the prosthesis clean. Well, there's enough open space. In other words, can you go back to that slide?
Yeah, the zygoma one.
Yeah.
This one, or is that? Yeah, I think it's up.
There's no, I mean, that slide is a
Yeah.
really good slide for showing zygomatic implants. But it would give a person the idea that there's kind of a trough around on the inside of those teeth that could be difficult to clean. And so whenever these types of teeth are made, they are not hollow on the inside like this slide depicts. Okay, this is a good slide to show zygomatic implants and how they work. But it's a poor slide to show the design of the implant-supported prosthesis. So the prosthesis is not hollow on the inside. The prosthesis is not concave. The prosthesis is convex. And it just barely kisses the gum tissue. So there's plenty of space to get under it with a toothbrush, with toothpaste and a toothbrush. We do not recommend water picking around zygomatic implants, but toothpaste, toothbrush, dental floss, and you can clean them without any problem if they are designed properly. And that's the key, designed properly.
Yes, and we will help you with all of that education as well. And then last is kind of more like a comment, but I think it's good to touch on, is about like for people who are afraid of like our staff or those that they're interacting with, like judging their teeth or like, you know, just because we see a lot of patients that have teeth issues.
A lot. Nobody's going to judge.
Yeah.
Nobody's going to judge you. I can just tell you that right now. I mean, we see, every day we see a couple of new people for consults. We're doing the procedures. We see all different kind of stuff, but I mean, that's just what we do. I mean, it's just no one. I saw a lady yesterday. She was so nervous that the first appointment she made, she couldn't even park in the parking lot. She pulled around the office and had to leave.
Aw.
She was that nervous. And she made another appointment, and she was able to park and get out. And she came in the front, and Chastity had to go meet her up front, and she was crying. And one of her issues was what that question was, that her situation was so bad and she was so embarrassed. And, she had a lot of anxiety about that. And so once we got her in the back and talked to her and reassured her that, no, nobody's going to judge you about that. I mean, that's crazy. We would never do that.
We try to make everyone really comfortable.
I mean, that's why you're here. I mean, you have to kind of hand it to you because you've recognized the problem and actually took some action to take care of it, and we're here to help you. And so nobody's going to judge. Nobody's going to judge anybody for that.
Yep.
Absolutely
and that's a big
not.
first step to even call or even come in. Like
Yeah.
sometimes that's like the hardest part for a lot of
I've
people.
talked to a couple of people in the
Yeah.
last 10 years. They could barely park in the parking lot. I mean, that's
Yeah.
fear and anxiety,
Yeah.
So.
Well, that's really good. All right, let's see. Oh, we're still on zygomatics, but this is our final final zygomatic.
There you go.
This
I like
is
that
no
slide.
bone at all. What are we looking at here?
So I'll tell people we see some people that have good bone in the front and they have a good bone in the back. And we do the traditional technique, the one you saw, first slide, tilted on the top, tilted on the bottom, traditional implants. And then we see people that have good bone in the front but no bone in the back. And that's the last slide that you saw, where there's 4 traditional implants in the front, a zygomatic in the back on each side. So they had good bone in the front for traditional implants. Now you come to a segment of people that have no bone. No bone in the front. Can we do the red dot on that? Or no?
Draw. Want to draw?
Well, I'll try to do all that technology stuff. So we see, and actually, last week I did 2 of these. So, that's like 8 zygomatics. You want to talk about doing zygomatics.
Wow.
And so, right in here, you
Press output.
hang on just a
And then you
second.
can draw. It'll pop up.
So right in here, well, it's not
Press
showing up. Maybe it will now.
1 second. What are you trying to do?
Well, we might get the Buddha to come in here, and we tried that, Keith.
Technical difficulty.
There you go.
Here we go.
So right in the
Okay.
front, there's no bone. I mean, you can see just, right here, there's just almost nothing. So there is a segment out there, and it's pretty common. And these people, it's kind of interesting that this category of people come from all over the place to get this done at our office, because we're known widely that we do this. And if you look, this gives a better shot at where the zygomatics are. If you look right up here, and I'll say it again. If you look right up here, this is the eye socket, right up here. And so there's plenty of room in the cheekbone to put those in. So these are the third category of people that have no bone in the front, no bone in the back. And so we do 4 zygomatic implants. And they get a whole full set of teeth the same day.
Mm-hmm. It's amazing.
So,
Amazing.
And they have been all over. And they find us on the internet. I don't know how they find us, but they do. It's crazy. So, quad zygomatic technique.
So if you have been told you cannot get implants because of bone loss, you just need to come visit us.
Yeah, you may be a good candidate for a quad zygoma technique.
Yes.
What would prevent you from being a good candidate for a quad zygoma technique would be if your sinuses are all messed up. If you just, if your sinuses are all congested and full of stuff. Your sinuses have a lining, a membrane called the Schneiderian membrane, and it's composed of cells, and these cells make mucousy fluid, and there's little hairs in there called cilia, and they push this fluid up and push it over into the drain hole to push it over into the nose. And as long as the sinus is functioning normally, then we look at the sinus on an x-ray, it'll be totally black, which means it's clear. And then you'll look at a sinus that it has maybe a little bit of black in it, but the majority of the sinus is all kind of whited out, not healthy. So those people we send to ENT doctors to get their sinuses healthy before we would do a quad zygoma technique, or even a single zygoma technique for that matter, because we don't want to put a zygomatic technique and some of the zygomas actually intrude on the sinus a little bit, and you don't want to put one through an infected sinus because then the whole thing will get infected.
Yes.
So, but anyway.
And we did have a question come in about no bone on the bottom. So what are
No bone on the bottom?
We kind of discussed a little bit of it, but
Yeah. Well, it depends on what do you mean by no bone on the bottom. I mean, we see people that come in and they've been told they have no bone on the bottom, but they really do have bone on the bottom. So if somebody has 10 millimeters, 10 millimeters is not a lot, but if they have 10 millimeters and it's not knife edged, now if it's knife edged, that's a whole different story because you cannot put traditional implants in. So if you have 10 millimeters and it's reasonably thick, then you can have traditional implants. But if not, there is a subperiosteal implant that can be done, and they work very well. And that would be the type of implant that we would recommend for someone who truly does have very little bone and it's really skinny and thin and not enough bone to put traditional implants into. Typically, we're not bone grafting because bone grafting is painful and expensive, and you would have to go in the hospital and have bone taken out of your hip, and it's just not something you want to do. So the subperiosteal implants certainly have a place in implant dentistry.
perfect. And we did cover this as well, but it's just a quick answer for someone. They have a lot of broken teeth at the gum line.
Yeah.
Would you remove those?
That's not a problem. Broken teeth, if you have 30 broken teeth at the gum line, it's not a problem. If you have 6, we just take them out. That's what I've been doing my entire professional life, is taking out bad teeth. So we take out the bad teeth. Now when the bad teeth come out, the bone is irregular, it's sharp. So the tissue has to be reflected back and the bone has to be trimmed and smoothed, just like the person was going to be getting regular dentures. So the teeth come out, the bone has to be smooth. Then we can use a little instrument like a little hoe and go in each tooth socket and clean out all the infection, and then wash it out with saline that has antibiotics in it, and then place the implants and do the micron mapper impressions and the scans and all that, and then you can get your teeth that day. So one thing, and I said it earlier, what we do not do is we do not take the teeth out and put you in dentures for 6 months and then place the implants later. And we take the teeth out, put all the implants and everything in, and in 6 months you'll be in your final teeth. You'll be done.
Yep.
Rather than just starting. So if someone's trying to put that onto you, that is like an inexperienced person you need to run. But, so it doesn't matter how many teeth you got. It doesn't matter how bad the periodontal disease is.
Yes.
We can take care of it all in one
Definitely.
day. Yeah.
And this is Dr. Richards' team, so when you come in, if you become a patient of Dr. Richards, you'll get to know these ladies very well, and they will be with you from surgery to post-op checks and all of that.
Yep. And if you're a Spanish-speaking person, the young lady on the right, Marilette, is of Mexican descent, and she's fluent in Spanish, so
Yes,
you would
that's
be
always
comfortable
helpful.
with somebody to talk to.
And then our restorative team, we have Dr. Nafala, Dr. Dibbs, and Dr. Perez. And we are going to hear from Dr. Dibbs to kind of explain how the lab and the restorative team work together so closely for our patients.
One of the things that really sets Florida Dental Implants apart from other offices that are doing full mouth implant reconstruction, I have my own laboratory here on site that myself and the other restorative doctors are able to use. This is invaluable. Having the ability to work so closely with my lab gives me the ability to better help my patients with the emotional side of it as well. A large number of the patients that come to us for treatment have had severe dental problems for many, many, many years, sometimes dating back to childhood. Because of the emotional concerns that they have, we really have to spend the time with the patient. That you can't rush anything. We need to have ample opportunity to have questions asked and answered. Having my own laboratory here on site, this is invaluable, not only in terms of having the control over the quality of the product that we're making, but the ability to, if I've got a question with the patient about, can we make this change? Is this going to be feasible? I can go across the hall, get one of my lab technicians, and all of my lab technicians have been doing this for many, many years. Bring them across the hall and they can talk to the patient themselves. So we eliminate the need for me to try to interpret the patient's concerns and questions and needs in a phone call or in a note. They can speak directly to the patient.
It was so important to me to have everything under one roof. There's no waiting. That is the advantage of having the lab on site. And they are so proud of their work that they come out to see the product. These are not regular people with regular jobs. These are master artisans that create. They truly are artists. And they're creating beautiful smiles.
It's like nothing I've ever experienced, and I don't know of any other office that's like this.
And these are our implant coordinators, so if you did come in for a consultation, you would meet with either Shauna, Chastity, Allie, or Crystal and go through the whole process. So the consultation, first we'll take a CT scan and develop a treatment plan with the exact fees. You'll also meet with Dr. Richards in person, and he'll go over that whole scan with you and basically exactly what you'd be doing for surgery.
Right.
Ask any questions, all of that, and finalize that treatment plan and get you final pricing, all of that, so that you leave knowing what would happen if you went through a surgery and feel very informed about the whole process and the whole plan for your specific situation. And then to give you an overview of the whole process, which we have touched on quite a bit, but so you'll come in for the consultation. Let's say you're ready to move forward. The next step is going in for a pre-op and impressions appointment before surgery. And then we have our new tooth and mouth surgery day, and then several post-ops to make sure everything is healing properly, and like Dr. Richards was saying, like possibly changing some things with the fit of the teeth and that sort of thing. Then about 6 months later, you'll start the final teeth process where you'll create those final zirconias, make any aesthetic changes, all of that, and then we place finals. And then it's just looking at like normal day-to-day maintenance, which if you
Yeah,
want
I mean, we have a
on that
hygienist,
is.
we have a
Yeah.
hygienist. We're gonna include still, I think, a couple of years of post-op
Cleanings.
checkup visits are included in our process. And like I say, we now have a hygienist who is taking over most of that cleaning. And you know, a cleaning appointment with one of these is not sitting there with somebody picking on your teeth.
It's way easier.
You know, this is where they actually unscrew the teeth, they take them out, clean up the teeth in the ultrasonic, kind of freshen them up real good, check the connectors and make sure they're all tight, and then put everything back together. And then one of our restorative dentists would take a look at you and check the occlusion. That's the dental term for the bite. They would check the bite and then set you up for next year's visit.
Yes. So it's very simple. And we are going to hear from David. So he dreaded going to the dentist and was always having to fix his teeth, and it just affected his day-to-day life. And we're going to kind of see how that has changed for him.
My name's David, and I'm a real patient at New Teeth Now. I associated going to the dentist with pain. No matter what I did, there was always a fix and then another problem. And it just got to a point where that's all I was doing, was chasing problems. That's when I knew I had to call New Teeth Now. Dr. Richards took the time to explain all the pros, the cons, and made you feel comfortable with everything. The days following surgery, I had very mild swelling. Pain was very minimal. Didn't even take the narcotics that was prescribed. I took Tylenol and ibuprofen. The greatest part is no more worries about what's going to happen to a tooth if I do this or I eat this. No more trips to the dentist. No more anxiety laying in a dentist chair. No more, broken teeth while I'm traveling on the road. No more fear of how much is it going to hurt when they do this. Enjoying just life now. I don't have to be not in the conversation or keep my conversation short or wonder what I'm going to say and if I have to react with a laugh or a smile. I just get to be me, and that's the best part. My wife loves to take pictures anytime we're out on the bike, selfies together. Everything revolved around my smile. You would not think it would, but when you make this change, you realize how quickly that everything did revolve around whether or not you smiled or didn't smile or how much you enjoyed it. It affected your day-to-day. Now with that being fixed at New Teeth Now, it's gone. You don't have that day-to-day worry. You get to enjoy your life and do what you want. If anybody's worried if they should or should not, or if this is gonna work for them, do it. Pull the trigger, get it done, because when you come out of the other side of this, you're gonna wish you'd have done it sooner. The value is really, people try to quantify what they get for what they spend. There is no number you can put on this. It is the best decision I ever made in my entire life.
So, like David just said, the best decision of his life, and he just felt confident again and having fun again with no worries, and just didn't really even think about mentally how much he was concerned about visually how he was appearing, which you don't really think about till afterward,
Right.
Really, really good. So, we talked about these a lot, but just to reiterate, our key
Right.
differentiators and why they're so important is that we do have further resources for you to check out. If you do stick around on YouTube, we have other webinars, we have more before and after, videos and testimonials. And then on Facebook and Instagram, we post a lot of before and afters and just a lot of great content, a lot of educational content there. And on TikTok as well. So we're all at New Teeth Now. It's easy to find us. And then on Facebook, we have a community group. So if you typed in New Teeth Now Community in the search bar on Facebook, it'll bring up this group that you can join. And it has almost about 700 people on there now.
Wow.
Yeah, it's grown quite a bit. Mostly current past patients, and then some that are deciding and looking for treatment. But it's really great because you can talk to other patients, get their opinions, ask questions, and just hear from our community. So it's a great resource. But we really appreciate you joining us tonight and asking great questions. And we just encourage you to give us a call. We'd love to talk with you and just see what you need.
Just to mention, we've also done some video consults.
Oh, yes.
Like telemedicine
Yes,
consults.
we can do that for out-of-state
So
people.
if somebody has a CT scan and you live in Detroit or whatever, then we could sit down at the computer and basically do a complete consult.
Yes.
And so, you know, what happens, a lot of folks, they'll get all their medical clearances up at home and send them all down to us. And then they just come down and have the procedure, so.
Yeah, so we do
Just-
try to combine as many appointments for Odyssey
Yeah.
as possible so
Yeah.
that you don't have to make as many trips. But
All right.
thank you guys.
Good
We hope
night.
everyone has a good evening.